In today's Young Oncologist session, you talked about caring for the LGBTQ plus cancer patients. What do you think is the biggest challenge regarding this topic?
So I think it's starting with the basics and encouraging LGBTQ patients to disclose their sexual orientation or gender identity to us as physicians, particularly those in places where the culture might not be welcoming of them and where they face stigma and discrimination. So that's really the first step in building a safe place within the medical community, regardless of what's going on around us. And from that, we'll gain personal insights into their needs because they'll trust us to tell us. And then we can also start to systematically collect that data, because currently we don't understand the scale of the health inequalities because we don't ask and we don't record it anywhere. And so I think that would be the second biggest challenge, is actually good epidemiological data that's collected in a high quality way with lots of the other information about patients. That's really important so that we understand what's causing those health inequalities.
What needs to be done to improve the situation?
So I think everything starts with education. We know from the literature that healthcare professionals won't ask about sexual orientation or gender identity unless they start to understand why it's important, but they don't know why it's important unless they ask. So it's a bit of a vicious cycle. So educating people about what we know now and why it's important to ask will have that feed forward effect. It'll start to generate that data, to improve the research, then to upskill the education. So the piece around education, the piece around encouraging disclosure is really important to kind of build that evidence base. And I think then moving that onto a policy level. So it's great to see that LGBT cancer care is on the ESMO ASCO global curriculum. And actually we need to make it part of our healthcare policy to be non-discriminatory. And then also where tailored care is needed to provide it. So I always say you wouldn't ask a patient where the language you're speaking is not their first language to make do without an interpreter. In the same way, where there is an additional treatment need, a discussion about side effects that's relevant to one subpopulation, something else different that we need to think about, then we need to be providing that. It's not equal care, it's equitable care, and that's what we need to be aiming towards.
So is there any practical advice that you would have for your colleagues that they personally could follow?
Absolutely. So where there is education, take it up. There are a number of great places to find education. Today in my talk I spoke about an organisation called Queering Cancer, which has great resources, and also an organisation which is patient-facing but also educates professionals, called Outpatients in the UK. So firstly, that baseline education, and there's no substitute for seeking that locally, in which the culture where you are. Then start with the basics, doing what we should be doing for every single patient. How would you like to be addressed? That elicits the person's preferred name and their preferred salutation or pronouns. You don't have to say, what are your pronouns? You have to say, how would you like me to call you? What would you like me to say in the letter? And actually that's important for every patient. There are patients that go by their middle name, for example, for all sorts of reasons. So starting with the basics, who have you brought with you today? Not assuming that person is a partner, a friend, start with non-assumption, and that will elicit trust. Put as much as is safe where you are, up in your office or your hospital or place of practice, that can be welcoming. If you're in a culture where it permits it, rainbow flags and posters that say yes, it's okay to be who you are, and that show people with their same-sex partners. If that's not accepted where you are, then do what you can. So speak to people in the community and community organisations where you are, build those networks and work out what are the signals that you could send in your practice that the majority of people might not notice, but are actually really welcoming to the community, so that builds that trust. And as I've said, it working with the community, so everything should be co-produced. Any little piece of research you want to do, any improvement, make sure there are people who are LGBTQ within your team, involve LGBTQ colleagues, bring your lived experience and feel that you're able, if you can, to offer a bit of that into your practice. And it will escalate from there. We can all do our tiny bit, and actually gradually we will change culture and we will change outcomes.
Perfect, that sounds good.